Good afternoon.
Good morning, Edward.
Good morning, Phil. How are you doing?
I'm good. Yourself?
Good. Thank you. Kind of bored with so many Zoom sessions. This is my seventh.
I was only saying to Cass this morning, I was saying, yeah, I quite like Zoom now and again, but geez, when you're on it all day, it starts to get a bit of a challenge, doesn't it?
Yeah.
Did you, just quickly, whilst I've got you, did you get my email catching up with Caroline Robinson this afternoon?
Yes. I'm sorry I didn't reply.
No, that's okay. I mean,
yeah,
and you may not have anything that's relevant, but I just thought if you've got anything that you could point me at, which I could just prep myself, that was all.
Yeah, we actually had a good conversation last night with, well, this morning for her, I think it was whatever. Last night, yeah, for us with her and with Stuart Cohen.
Right. Don't know Stuart.
Yeah, so we from Regenerative Communities Network,
Right.
Institute. So we're getting aligned on the road mapping process. I'll brief you on that. I'll answer your email. It's just I've been overloaded.
Yeah, no, that's fine. That's fine.
Good.
Okay.
Thank you. Let's see. Okay. So we're at 1300 CST time. I apologize for those that got in early. It has happened that since it's a transition to the summertime for many places, that some of the pages don't update the CST time. But we are now getting ready to start. I see Enrique's here. Mike, are you on the call? I saw you.
I am, yes.
Yeah, perfect. Thank you. So I just wanted to give a brief introduction and maybe just go over a few of the aspects for today, what we're expecting. And then I'll just let you go. Thank you, Enrique, and thank you, Michael, for being on board. Enrique is at the PAHO World Health Organization, and Mike is one of the well-known people that deal with risk and emergencies, and he's been running a bunch of activities. I'll let them introduce themselves in a moment. The idea was to be able to discuss the COVID and what it actually means, and then try to develop some strategies for community resilience through regeneration. So this is actually an applied part of this webinar series within the Certificate of Regenerative Entrepreneurship. I decided to open it up to the public because we have these two brilliant experts with us, and it would be a lost opportunity not to open it up. So we have now participants from around the world, and it is extremely difficult situation to deal with the lockdown of the COVID and the economic crash, and people getting already uneasy that the businesses are going kaput, and that a lot of people have lost their jobs already and are not able to purchase even food. I'm myself involved in several initiatives at the Costa Rica level where the tourism sectors that have basically kicked out all the people are living off charity, and people that are volunteering to collect food, but that we have to really shift into self-production and move them from former tourist workers to start producing their own food and regenerating communities in their livelihoods, their cooperation, and getting them to actually go into a self-sustained process. So we have more and more pressure every day on the governments. Right now, We had actually a conversation with Mike and Enrique and the Minister of Environment last week. And as in many countries, there's a lot of pressure from the corporate sector and the business sector to reactivate the economy. And a lot of it is by easing the environmental protections. We've seen that happening in a big country up north, where with the excuse to reactivate the economy, they're taking out all the environmental barriers to companies. They can pollute the rivers, they can pollute whatever. So I think it's very important that we understand that we should try to bounce beyond and not bounce back to the economic model we had. And I think that is a lot of what I hope to be able to cover today in our discussions. How do we actually bounce beyond the situation? How do we bounce to a new regenerative well-being economy and not go back to the same model that brought us into this problem? Nature is letting us know that we have gone too far. And actually she's letting us know softly because planetary collapse due to biodiversity loss, due to climate change will be affecting most of the population on the planet and not just a few that is actually happening with the virus. So I think it's a good call to reflect and a good call to start with actions. And we need to kind of forget about all these theoretical things and discussions and going to very practical things. We need action. We need to be able to start very quickly helping communities to fend themselves against the harsh moments that they're facing. Otherwise, we'll see the collapse of many of the countries. We're already seeing in Latin America, in Colombia, in Mexico, in Ecuador, people robbing supermarkets and just forgetting about the normal social norms. And if somebody's hungry and has kids and does not have money to buy the food and doesn't have where to get food, they'll find ways to feed their kids. So I would like to pass it over to Enrique Perez from the World Health Organization, PAHO. And he's going to give us a brief introduction about the COVID and so on. And then I'll pass it over to Mike. And then we can have an open discussion. Enrique, please. If you want to present yourself shortly.
Sure. Thank you, Eduardo. And hello, everybody. Good afternoon. My name is Enrique Perez. I work with the Pan American Health Organization. I am based in Washington, D.C. My normal work is being the unit chief of the Health Information and Risk Assessment Unit as part of the Health Emergency Department in PAHO. Since January, I am in charge of the, well, you know, when we have this type of emergencies, we have in the emergency response framework, what we call the incident management system. So, and as part of the incident management system, I am coordinating the pillar of, I think this one, there's an echo there. I don't know. I'm sorry. And I'm of epidemic intelligence. So I am a veterinarian as background, and I have a PhD in epidemiology, and I work with PAHO a lot of years. I think now it's more like 20. So we are getting older. My job is with you guys is just to present the context, what's going on in the COVID-19 in the Americas, but I will do a general introduction about the world. And so you have the data globally, and I will just pinpoint some specific topics that could be important for the discussion afterwards. It's not a huge amount of slides. I will try to do it fast to not bore you guys. I think I can share my screen here. Let me see if this is the screen 3, I think. Share. Yeah. Let me know if you can see the presentation.
Yeah, it's clear.
It's clear. Okay, so I will put it in presentation mode.
You might have to do that before you share your screen.
Yeah, it's not working now.
No. If you close it, unshare the screen, then open it, and then share the screen.
Okay, so I close this. I lost the comments, my friend.
Yeah, you have to stop sharing, and then you put the presentation
Yeah, but
on.
Here's the comments in this part. Stop sharing. Okay, and now I have to launch it.
Yeah, and then you reshare the screen.
Okay, sorry about that. I don't like. Well, I don't have to say that. Okay. Okay, this here, but where is the command for sharing? If
you have too many screens.
I have 3 screens in front of me.
Okay, yeah, you're not sharing.
Okay, just hold on a second. Let me see if I can see it. Yeah, but I don't have the command for sharing, Eduardo.
Yes, the same one you used last time.
Yeah, but it's not with me now. I'm not seeing it anyplace. Okay, let's do it without. Let's do it without the presentation.
Try again. Try again. You go back to the Zoom main window.
That's okay. That's okay. Let's do it in this way.
Okay.
Share. I think you can see it.
Yeah.
It's not big, but you can see it.
Yeah.
I think it's big enough. Okay, let's go. So as I mentioned, the idea is to present to you some of the a background of the epidemics. I think now you're seeing an epi curve. Being an epidemiologist, not presenting an epi curve is like it's like a scene. So what you're seeing here is the whole epidemics until yesterday, beginning with the first cases on the 27th of January in China. And then how it comes growing exponentially since then onto today. What you see in the different colors is the WHO region. So as you know, we have 6 regions. We work with we have the Americas, the Eastern Mediterranean, the Europe, Southeast Asia, Western Pacific, and those are our 6 regions. And you can see, I will not detail too much, but what we are seeing is the amount of cases, which is the bars, and the line is the amount of deaths. So is actually a huge amount of cases, and I will present that later on for you, the exact figures. This is what happened yesterday in terms of countries presenting the biggest amount of cases. As darker the color is, the amount of cases is bigger. And as you can see in our region, United States is our epicenter, right? So, and in Europe, you can see Spain and being the country which more quantity of cases, but also, well, all Central Europe in general is having more cases now. In this slide, you see the same information, but it's not cases, it's deaths. Okay, it's people who is dying, and we have to take this into consideration. When we work with this, we talk about numbers, but it's not numbers, guys. We are talking about people. We are talking people which is dying, and we need to do something about it, and we need to work as much as we can to diminish the people dying and getting sick. This is the Americas. Since I didn't have time to update it for today, but this was the numbers yesterday. In the whole Americas, we have the PAHO region, we work with 54 countries or territories, right? Territories is the territories from the French, the territories from the Dutch, the territories which are in our region. Even though those are not independent states, but we work with them, French Guiana as well. So, and those are 54 in total. And you can see more than 700,000 cases, more than 30,000 deaths. And in the balls, the small circles represents the confirmed cases, and the colors represent the incidents. As you can see, again, United States is our epicenter, and also the New York State being the most affected. This is North America, and just to let you know, by sub-region, Canada, Mexico, and USA. And again, United States being the most affected. As you can see, is more than 95% of the cases in the whole region are in the US, and 93% of the deaths. So it's a quite an epicenter, the United States of America now. And inside of the US, you have the New York State being the most affected in the country. But this is changing. Detroit and other cities are now getting into trouble as well. And what you see in the graph is the cumulative total cases, which, as you can see, is completely exponential, which is something that that we have to take into consideration. This is Central America, taking Central America from Belize onto, geographically, okay, from Belize onto Panama, and being Panama the country which have more cases in our region, about 3,500 and 95 cases. And again, you can see the curves down, where you can see the exponential curves of Panama, Costa Rica, and Honduras, which are the countries which more cases in the region. This is South America, and you can see about 60,000 cases and about 2,500 deaths in the region, and in South American region, and being Brazil, the country with more cases, and this is increasing now that they are improving the data collection and of course also the testing. So this is increasing, but remember that we got some weeks ago an epicenter in Ecuador, especially in the city of Guayaquil, which was very, very hard with a lot of deaths. Almost all these deaths that you are seeing here in Ecuador were in Guayaquil. Chile, Peru, and Argentina also presenting, and Colombia presenting some amount of cases, and you can see the curves, which again have all this type of exponential type of presentation. Okay, this is the Caribbean, which is the region that I'm missing, and again, it's the same. You can see the presentation is always exponential. Normally in these countries, in all the countries, the cases doubles each 2 to 5 days. This is what's going on, and you can see the amount of cases in the Caribbean, almost 7,000 cases, cumulative cases until now, and being Dominican Republic, which was the first island presenting cases with more than 3,600 cases and 190 deaths now, and you can see in the small circles represents the amount of cases, and the incidences is in the colors. So given this situation, what you can do? So in our case, we have three main principles or three main actions. The first one is to save lives. We need to save lives because there are a lot of people dying. And for do that, you need to have what we are working with the countries, or what the countries are doing is doing a real reorganization of the health services. They need to plan the surge. They need to plan how much normal beds and ICU beds, intensive care unit beds they need. And because having all this exponential amount of cases coming in the same moment, of course, the saturation of the service is a given, and so the countries are working and very hard in terms of this reorganization of health services, and maybe later on with Mike we can expand a little bit in terms of the resilience of the health services and how this how the health services should be resilient to avoid this problem that they are confronting now. The second one is to maintain the infection prevention and control, and this is in all the health services. So it's important that the people keep to avoid the healthcare workers working with the sick persons get infected and diseased. So the only way to do that is with good infection prevention and control. And to do that, they need personal protection equipment, and not necessarily this was available in every place, in every country. And you possibly have seen in the news the problems of the purchasing all this equipment to protect the healthcare workers. The next one is, of course, is to optimize the clinical management. We need to optimize how to work with the patients, and being a disease, a new virus that we didn't know very well the physiopathology of the virus. That is now we know, for example, this is affecting not only the respiratory system, but also is affecting other organs at the same time. So this kind of how to optimize the clinical management was a challenge, because it was a new disease, and of course, it needs, being a respiratory disease, illnesses, it needs a lot of equipment inside of the ICUs, and not necessarily this was available at the country level. So to assure the supply chain was also important, and not only for the personal protection equipment, not only for the oxygen, not only for all the let's say the medical supplies that were needed at the hospital, but of course it was important to have for the testing. Everybody said, okay, let's do a PCR, perfect, but it's not only to have the probes, it's not only to have the primers, you need reagents. And being a pandemic, everybody was looking for that. So to have adequate supply chain to the countries is a challenge, and the whole community in the Americas is working towards that, and of course my organization as well. The second pillar, which is quite important, is to protect the healthcare workers. Those guys are the front line. Those the people really doing the hard job, and we need to protect them both, not only at the hospitals or the first level of attention, whatever they are based, but also in the community. They have to be protected also in the community, because it makes no sense that they get infected in the community. And the third one is to slow the spread of, and this is what you guys are, between quotes, helping a lot in terms of the social distancing that you are doing now, right? But it was important to do the detection as isolation of cases, do the trace back and quarantine of the contacts, which will be more than important when we talk in terms of adapting or releasing the public health measures that we have in place. This will be something very important, and the countries should be prepared to do that. Secondly is to engage, of course, with the community, and you have a lot of this risk communication in how to wash your hands, how to do it properly with soap, and later on, if you can use some of the gel, also you have to use it, and this kind of messages that were that you got in all your countries. And of course, the implementation of social distancing and all the travel measures that were in place at the beginning of the outbreak. All these three principles, pillars, are based in having a good surveillance system, a good reference laboratories that can manage the quality of the test, and of course, all of this is to give us evidence, to give us information for action, because we need to know what is going on if we want to do it properly, the work with the community. I just want to, oops, if I can pass my mouse here. Good. Okay, the other thing which is important, and I want to do emphasis on this, because this is something that we will be doing at the moment that the public health measures are adapted in each country. Not necessarily is only this, because possibly we will keep some, the countries will keep some type of other measures like avoiding mass gathering. Possibly there's no more football games for some place. So for some time, there's no more concerts. There more the restaurants maybe will be open, but with not huge crowdness inside of the restaurants. So we have to be aware of that. But what will be very important in terms of the health services is capacity in terms of detection and capacity in terms of traceback, doing traceability of the contacts to do a proper quarantine, and in the detection do a proper isolation of the countries. This is something that of the persons. We have to be very aware of this. Imagine a place like a very poor setting in a country where you need to isolate, that you need to quarantine people. This is not easy, right? And this is something that we have to take into account at the moment that we are planning to do this, and the countries are being prepared. All the actions that we are doing now is to prepare. First was to prepare for the surge of the hospitals and the care, and now we have to prepare for releasing the public health measures to avoid the problems that Eduardo was saying at the introduction in terms of the social and economic impact that we are having. This is just to let you know some features that we can compare in our region. This is the age distribution of the cases in Italy and Spain. See how different it is in our region. We have, and this is mainly due to the age structure. As you can see, in Italy and Spain, you have a lot of cases with people above 50 years old, which is not the true in our region. You can see Colombia, for example, the main concentration of cases is between 20 and 40 years old. And if you see Chile, for example, is basically into 20 and 39 years old. And this is related with the structure, with the pyramid, or the population pyramid. We have more young people, more young people than in Europe. Possibly this factor combined with this one is about underlying conditions, and here I'm talking about chronic diseases. If you can see Latin America and North America, we have less proportion of persons with the blue line. The line is the age, and the other one is the proportion of one condition or two or more conditions. The darker is two or more conditions. The light is one condition. You can see we have less than Europe. See Europe. Possibly then the impact in terms of deaths in our region will be less, or at least we are expecting that it will be less than in Europe and of course North America. So this is just to let you know that maybe we have good news on this. Our age structure is something that of course we need to wait, but if the evidence that we are having now in terms of that the severity of the disease is more, you can see a more severe cases in the older people, having an age structure like ours and having underlying conditions in we have less underlying conditions than other countries, maybe the cases of the deaths will be less. Here I just want to go, if we do regional, let's try to see, this is New York State. And again, here you can see the case rate is the yellow one, as you can see, increases with age. The next color is, I don't know what color is this, but it's like a light, is the hospitalization rate, and the red one is the death rate. Okay. And as you can see, among people, let's say the 45, 50 and older, the incident rate is similar among all the age groups. But however, you can see the deaths and the hospitalization increases with age, right? This is about gender and about sex. You can see the case rate hospitalization is almost the same between males and females, a little bit higher in males. And this is happening everywhere, right? That you can have more proportion of men than women with more hospitalization and death. But this is very interesting. This is the distribution by boroughs, or by, if you can, let's use the zip codes, by zip codes in New York. You can see clearly clusters. Where those clusters are located? When you have more people, of course, but also when you have less income, right? And this is something that we need to discuss later on, maybe with Mike. I hope that Mike would like these slides. And this is will give him some munition, I think. This is the proportion of confirmed cases, again, by boroughs in zip codes in New York. As you can see, Manhattan, Queens, having the less the zip codes in Manhattan as the ones with less cases if you compare with the other ones in other places, right? And this is almost drive me to my last slide. I'm sorry, this is not about COVID, but I think it explains very well. This is part of my former life, but this explains very well what, in my opinion, what's going on is about the social determinants of health. The health doesn't, the disease doesn't occur because you have a host and you have a pathogen and you have an environment and they interact between them. This is a fallacy, but we were formed in that way. Is the typical ecological triangle, right? But actually, what is going on in diseases and in public health is that you have social and economic determinants, which are divided in two types of what we call the structural determinants, and this is mainly the socioeconomic position. This is about poverty level. This is about education. This is about ethnicity. This is about sex, gender. This is about demographic factors. And I think I put some examples to you. It's about living and working conditions. I think I put some examples in New York State, right? It's about also trade, right? And so all these structural determinants will combine and create some intermediary determinants that will create differential exposure and vulnerability in the people. People will be more exposed or more vulnerable depending on those determinants. And this is an example for foodborne diseases, but I think what I want is to give you the concept, right? For example, the modes of food consumption, it has to be with the lifestyles. It has to be with the behavior, some that you have. The modes of food handling. It has to be with the poor hygiene or improper food safety management of the food. But this is because you have some other bigger determinants causing that, right? Like the poverty, the education. If you don't have water, you cannot wash your hands. So this is why WASH at this moment, WASH is the water and sanitation, is very important in the response of COVID. Okay, so this is just to let you know that this is what is really driving this emergency. It's not only the presence of a new virus that is there because the social determinants, is not because it's not random. It didn't happen randomly. Happened because we enter in some place that we don't have, and there is a virus there's virus in bats, and the bat have a very weak immunological system, and the bat is capable of doing having and hosting these diseases. Some type of cultural thing make that the people like to eat those bats, and they went into markets and they create the proper environment for the transmission of the disease. And this is what we have now, a new virus coming from nature. This is just to let you know the highlights of headlines of the media, but you know that already. And I would like to finish with this. Finish with what we are doing and you are doing in your houses, being in your house, being together and working against using managing properly these public health measures. This is real data. It's a country. I just put out the name of the country because I don't want to use the name of the country, but it's real data. It's a very small country and poor country. What you have in color is the real cases. And this is a typical simulation model, compartmental model, typical of susceptible, infected, resistant, right? It's a SIR model, which is very useful and very common in epidemiology. What you see in the lines is the different scenarios that you can have. The perpendicular line, dash line, is when the country apply the public health measures, and the projection down, the light blue is basically what we believe will happen if they keep the measures. You can see the curve. This is what the people talking about flattening the curve. This is flattening the curve. Is having a small quantity of cases, but we are measuring here the cases using one epidemiological indicator, what is called the effective reproductive number. This is how many cases will be produced from one infected person. If you can do good control, you will diminish this effective reproductive number and avoid the exponential curves that's going up. What we are doing now with the countries doing this, with the countries in the region, is doing one of this model for each country. As you can see in the right is the effective reproduction number, how it goes in this country. And possibly they will be able to take out the measures, the public health measures by May 1st, because it will go nearby 1 or less than 1. That means that infected case as much will infect one more person or less or not nobody, okay? But this is why, again, I come back. This is an ideal type of thing, but remember that we will have people infected and we will need to diagnose that very fast, and of course doing traceback, detecting the context to quarantine, and the cases has to be isolated. And I stop here. I hope that it was clear to you, and I'm more than open for discussion, guys. Over to you, Eduardo.
Thank you, Enrique. I'll give it right away to Mike,
Okay.
so he can pick up from there, and then we have a discussion afterwards.
Okay, let me try to stop sharing here. Ready? Okay.
You there, Mike?
I am. It says that I'm not able to start video. I don't think it's necessary, but as long as you can hear me, I think it may require you to open up the video if you want to. And if we don't get it, we don't get it. It says that it's stopped by the host. But I'm going to start off, and I want to say that, first of all, Eduard, fantastic framing of the issue for today, which I think you laid out as community resilience through regeneration. And I want to say that I'm going to reveal some of my assumptions here. One is that there's still quite a few unknowns. We know that we build immunity, but because people are actually getting better. We don't know how long the immunity will last. We are seeing unusual circumstances in which people appear to be, again, either getting reinfected or are coming back into the illness. But they appear to be in fairly small numbers. It's my assumption that we're actually going to be in a long pandemic period. that we think that the cycle for coronaviruses go in roughly 3-year cycles. But the likelihood that we are without a vaccine and without a direct cure is probably at least a year, but more likely to be 18 months before we have wide distribution of the vaccine. And I think that Enrique and I agree on that. And basically, I agree with essentially everything that Enrique has laid out. I think he's done a brilliant job at covering a very wide territory. One of the, let's see. Okay, so I've restarted. Can you see me now? Okay, good. So the assumption is that we are going to have a very long pandemic. And the concern is that the approach that we are taking so far with the virus is being effective where it's being engaged in terms of flattening the curve. The problem with just flattening the curve is that we're not removing the volume of infections. We're just pushing it back across time, but with pretty substantial impacts on social infrastructure and economies. So the virus, how you want to attribute its characteristics, one way to think of it is it's basically a smart entity that is so far having huge impact on humanity. In the sense of a battle, the virus is winning. We have not really done anything to reduce the impact of the virus. We've just spread out the impact over time. In fact, in some ways, as we trade off the current cases and deaths with suppressing the curve, we're actually directly diminishing the functionality of our mission critical functions in our communities and societies. And that cannot go on for very long, and that's why there is a pressure to restart our societies. So you see that in the United States now, but it's also begun in China and other Asian countries. If you look at what is going on in Japan, unfortunately, they are into a very serious second wave, and that's what we're expecting is going to happen in the United States as well. But if you look at what has caused this pandemic globally, if we were in a different time in which there were, instead of 7.7 billion people on the planet, there were perhaps 2 billion or 3 billion people on the planet, and we did not have highly concentrated forms of fuel, which allows human populations to be highly concentrated, this virus would be much less effective in terms of infecting and killing people. If we had more circular economies where there wasn't the chance for as much translocation, where we're sending people all over the planet in planes and moving the virus around in very short periods of time. In many cases, we've had people be infected with the virus and then are in an entirely different part of the world now starting the epidemic and the element of the pandemic in completely different ecosystems. So now we've got the virus essentially in all of the ecosystems around the planet, with some exceptions. But what are we actually trying to do? In the short term, Enrique has laid out a very elegant description of the current approach to suppress the curve and to essentially protect our health systems. So to keep the capacity up relative to the populations that need to come in and use hospitalization, use ICUs, use ventilators. But we do, in many places around the planet, have healthcare workers that are getting infected because they don't have appropriate PPE. There isn't enough supplies around the planet to deal with the number of people that now need to access healthcare as we are currently organized in our societies. And in those places, healthcare workers are getting infected, and in many cases, they're dying. In New York, where I am now, we started out in Manhattan and chose to come out to the end of Long Island, where we have more space and we can actually control our environment to a larger degree. So our situation here, instead of being like in cruise ships where we had such high infections, we were in a building that was 48 floors high, and it's like a cruise ship just stacked on its stern going up in the air. So you have these highly concentrated populations, and in some cases where they have centralized air, as they do in many hospitals, by the way, you have high levels of infection in these super transmission sites. In addition, in grocery stores, where people have to go to get food, or have to have someone else go in to get their food, there is high levels of transmission. Other places where people are aggregating, if you're forcing people to go and vote in small spaces and they have to line up, that also would be a place of super transmission. So the way our society has been organized, it's a pretty effective way of having mass transmission of the virus. But the question is that really the way we need to organize ourselves going forward? And is that the favorable way to organize, given the other problems that we're facing as we look at the world under potentially a blue-green political economy rather than a petroleum and petrochemical dominated political economy? And the answer is probably no, we don't have to organize ourselves that way. We could potentially organize ourselves to be more in balance with nature and to live more smartly with a virus that is pretty well optimized to infect people and kill people under the current social structures that we've come out of and are now in a different transitional state. So what should we do going forward? Now, a little bit of my background. I was brought into a group called the Epic B Group in the late 1970s. Jonas Salk was one of the leaders of this group, and we would meet at the Salk Institute in San Diego. He was, as one of my thesis advisors, I was there during the time he was writing the book for the world, for the UN on world population and human values. And this Epic B group that I was brought into, sort of as a bridge to the future, was mostly older people in their 60s, 70s, the top of their game, running large institutions. The head of UNICEF, ministers from different countries, heads of corporations, heads of large nonprofit foundations, and so on. And they had two quirks. One was they all had looked at the world models at that time. Club of Rome was a dominant one. And they had come to the conclusion that they all saw that if we continued to act on the values and use the economic systems that we had at that time, that by this time in the 21st century, we would begin to see collapses of societies. And one dimension of that would be through epidemics and pandemics, given the concentration of populations, but also through the collapses of social structures of societies that had built, that had populations and built infrastructures that were in violation of the carrying capacity of those ecosystems and bioregions. So we are where we were predicting to be 40 years ago. The data I had been following since the late 1970s, and at first I thought, maybe this isn't true. But 10 years, 15 years into it, it became pretty obvious that it was trending as they were projecting. But the collapses are not necessary if we can bring our societies into balance with nature, within the carrying capacity of our ecosystems. We should be able to actually live within nature. Now, that is the foundation of resilient and regenerative systems that we're building. So I coordinate the Alliance for Global Resilience and Regeneration, but also I run the Global Health Response and Resilience Initiative. So I've been going into the big disasters all over the planet for about 30 years now, with a higher concentration after 2000, because I had taken a company public and I now could actually spend pretty much all of my time focusing on prevention and management of large-scale social crises. And the purpose of that was to see if, in fact, we can change the circumstances at a global level to reduce the probability of collapses at the level of societies and at the level of communities. And what we now know is that we are not only probably going to see collapses, we are seeing collapses. And the current circumstances during this pandemic and after this pandemic, we are going to see an acceleration of collapses. Essentially, the pandemic conditions are a collapse of the petroleum and petrochemical political economy. Now, can it be restarted? It is the full intention of the President of the United States to restart the petroleum and petrochemical political economy. Now, what will happen if he does that? I'm going to guess, I don't want to put words into Enrique's mouth, but I would guess that Enrique and many of the people that are working at PAHO and WHO are frightened by that prospect, because it will most likely accelerate the number of cases and deaths. And I think all of the science that goes into public health today would indicate that that will be the case. Now, I take a different stand and say, and I think it may be aligned with Edward and others on this, this call, that we don't have to restart the petroleum and petrochemical political economy. We have an alternative path. The alternative path is to focus on mission critical functions. And one of those mission critical functions, and one that's very close to my heart as a doctor of public health, is to ensure the health and human security of our people within our societies and within our communities. So can we take a position that that is a fundamental element of what we have to achieve, but that it's insufficient, because we may actually see more people dying and growing ill and with collapsed quality of life, collapsed functional life capacity, if we take a path of just sequestering people to the degree that our economies collapse and our social structures no longer function. So what we're looking at is, how do we maintain the 26 mission critical functions that keep societies going toward resilience and sustainability versus moving toward higher vulnerability, extreme vulnerability, and collapse. So we are focused on looking at resilient and regenerative communities and societies and what are their outcomes. One of the attributes that we're looking at and we consider to be fundamental is that large-scale lockdowns are an extremely blunt instrument, that in fact they will kill large numbers of people from the secondary and tertiary cascading effects of the pandemic if we have to continue self-sequestering for more than another month or 2 or 3. So the pressure to restart our economies and protect our social infrastructures are going to be overwhelming. But what if we look at the demographics and the prevalence of the virus, the cases in different portions of the population, and the morbidity and mortality that's created in those demographics. And we take perhaps a smarter strategy in our battle against the virus and look at the possibility that there are, on a stochastic basis, not a deterministic case, that we could have a strategy that actually could do less harm by enabling populations that are at low risk to be part of restarting the society while keeping parts of the society self-sequestered. Now, that's a different approach than currently just the releasing of lockdown would have on our societies. So I'm going to just stop there for a moment and point out again this dichotomy and ask the question to the group, because I want to make sure that everybody's understanding what I'm suggesting. Do you understand the difference between the current model, which Enrique has laid out, I think very eloquently, and which I support up to this time? We needed to do this to understand the nature of the virus, how it moves through the society, how it impacts us directly, and how it impacts us through cascading effects. So there's nothing wrong with what has been done so far. It has had to be done as it has with flattening the curve. However, we need to restart elements of the society to ensure that, for example, we have access to food supplies. I'm going to use that as an example of a much broader set of mission critical functions that we need to also make sure that we're protecting. So I want to make sure that everybody understands what we've done with flattening the curve and allow questions to Enrique or to me regarding that strategy, but also now to reflect on the possibility that we could take more of a resilience approach, which would include considering the possibility of smartly achieving some element of herd immunity, which would reduce the transmission of the disease through the population, not only through behavioral and social resistance to the virus through self-sequestering behavior, and the possibility that we can use the current transition to move toward the reorganization of society to become more sustainable, as we are now at 7.7 billion, potentially on the other trajectory of restarting society, going toward perhaps 9 or 10 billion before we actually peak in population. Now, can we actually create these regenerative communities and societies? And the answer is, in my opinion, yes, because it's been done before. In the pre-petroleum and petrochemical political economies, we had thousands of years of organizing ourselves in ways that was more in balance with nature. And that is within human capacity, but can we do that with much greater intelligence so that we can also preserve more of our quality of life and functional life capacity simultaneously. So I'm going to stop right here and just say that I am not a fan of keeping the national and state level lockdowns as they have been. I'm also, though, a fan of continuing social sequestration of the high-risk populations, while also ensuring that they can still participate in the society, because a lot of our leaders are in the age groups that have significant impacts in organizing our societies. There is an embedded intelligence and knowledge base that should not go to waste. But if they're only oriented toward restarting the society as a petroleum and petrochemical political economy, that may be adverse to what we need to achieve in terms of regeneration. However, if we can increase levels of greater intelligence, collective intelligence from the bottom up, we can keep the virus out of our homes, out of our neighborhoods, and out of our communities. It's being done now. Can we do that while being more productive? That's the question I want to lay out to the group before we go on deeper into our conversation.
Anybody who wants to make a comment or ask, just open your mic and talk, because we don't have.
Good morning, Mike. Phil Tate, down in New Zealand. I'm interested in terms of what it seems to me is that, is this not a scale question? We're possibly unusual. We sit on an island and we're talking still about eradication of this thing. But I have seen commentary around some of the strategy that you're advocating that suggests that if not done correctly, you potentially end up with almost an apartheid situation, where you have effectively two types of individual in a society: those who can freely mix and move and have some form of immunity, and those effectively still sequestered. And that by making that distinction, you could drive unfortunate behaviors, for example, people deliberately infecting themselves, to become part of that more flexible community. I just wondered if you had any thoughts on that dimension of that suggestion.
Well, first of all, I want to celebrate and bring up to the group the success of New Zealand so far, because I think you have flattened your curve to a great degree. I'm not sure what the likelihood is that you can eradicate the disease entirely from New Zealand and wall off New Zealand from the rest of the world. But I do believe that New Zealand perhaps has been living as a more capable blue-green culture with a blue-green economy for a much longer period of time, perhaps since the 1960s, and perhaps with threads that have continued throughout its history. You also have cultural groups within New Zealand that live very comfortably and in ways within nature. So that's another factor I think that's very important for New Zealand going forward in terms of the Maori. The issue of having two elements of the society that which can participate fully in the activities of the society, and another that can't because of their risk to this disease. I think it is a factor. The question is, can we ever get effective immunity through vaccine? And the answer, as far as I know, is we still don't know. But my expectation is that we can. It just will not happen for periods of time. So is there a way to enable sequestration of individuals, but not only individuals, of also neighborhoods and communities in which we can know where the virus is and where the virus is not. And that way we could actually have higher risk populations living a fairly high quality of life and functional life capacity. So for example, if I were in New York, in our apartment in Manhattan, I would not be able to go out very often. And I think there would be high levels of concern each time I went out. Where I am now, I'm living on a bluff above a beach, and I have the ability to actually travel around many miles each day without any fear of being infected. Yet in our resilience capacity zone, which is the Springs of East Hampton, in our resilience capacity zone, our community, if you will, there has been a doubling of cases just in the last week. And it is considered to be one of the most intense hotspots out in the eastern end of Long Island in the world today. So I'm over 60. I'm in a high risk group. I don't have a lot of comorbidities, but definitely I'm in a group that does not want to be exposed because of the potential severe illness and possible premature death. Yet my quality of life and functional life is not limited. Now, if I were in Queens, I probably would have already been infected and probably would have had to be in the healthcare systems that have essentially collapsed. They are dramatically overwhelmed. So our circumstances mean a lot in terms of our ability to actually control how we are affected by the virus. Now, I don't know if I answered your question or not, so I want to just check back in with you. But there is the possibility of living closer to nature and within groups that have built a collective intelligence at the local level that is not terribly restrictive. Doesn't mean you have to live in a cubicle to achieve that.
Yeah, thanks for that, Mike. And yeah, I can understand the intent and appreciate also that it's a little easier when you're surrounded by a vast body of water than if you're effectively in the middle of 50 states. And with obviously all the porous nature of the sort of the linkages around that. So it's a pretty thorny issue.
Yes. Other questions or comments?
Yes, we have one from Thomas who's waiting for them to connect the camera. And also Luis Daniel. I don't know, Luis Daniel, if you want to make the question yourself, you put it on the chat. If you can connect speak out.
Sure.
Yeah, go ahead.
Hello, thank you for the opportunity. I'm talking from Costa Rica. I just wrote, sir, that, I mean, there are before this pandemic, we already had at least two very severe threats to global life as we know it, at least human life, which is the nuclear one, and the other one is artificial intelligence. So I would love to hear your opinion about these two very real threats from the regenerative development standpoint of view, in terms, since they are not going away. I mean, petrol can go away, but we still have nuclear and artificial intelligence, which is a real challenge.
Yes. So I've been involved in two nuclear events. I helped set up a wellness-oriented health system within a power company, one of the largest privately held powered companies in the United States, and which is probably was one of the largest in the world. And so I had been in nuclear power plants. We also, I helped evacuate people from Fukushima City and from their hospital right after the tsunami there, the earthquake and tsunami. So I'm familiar with these issues. The nuclear issue is a major concern, and it's going to go on for some time because we have huge stockpiles of highly toxic materials, and we still have weapons that are enough to destroy the planet, humanity anyways, and a lot of life. So that has not gone away. Theoretically, the Cold War tension has been reduced, but actually we may be in a situation where rogue states are acquiring more capability, and that knowledge is being spread. So that problem has not been mitigated. On the artificial intelligence side, I have a slightly different view, perhaps, than the way you phrased it. First of all, I think the concentration of intelligence is a good thing. And we think of it as such within humans in most cases, but humans, high levels of intelligence without high levels of humanitarian virtue is certainly a problem. So if we're embedding information that is structured into machines that now are capable of replacing humans within our societies, and the only focus of the society is on productivity, that does a lot of damage just simply by displacing people from livelihood. In addition, when you start violating the rules for robotics as Asimov had laid them out, as we are doing with drones that are essentially autonomous flying robots, but we usually with, at this point, human directed, that is a slippery slope that goes toward possible lethal machines that have an intent to kill humans. We aren't really at that place yet, but there are other significant problems with artificial intelligence that we have to take into consideration. However, we're at 7.7 billion people on the planet, and we have very substantial challenges being in the transition that we currently are in to get to a point of resilience and regeneration. And to be able to do that without some levels of machine intelligence may be very difficult. So then you have to look at what kind of machine intelligence are we talking about? Are we talking about adaptive intelligence that is essentially helping humans do things a little smarter, like GPSs? I would imagine you're not concerned that people are using chart plotters in boats or a GPS on their car to navigate with, but maybe you are. When we go from these technologies that help humans make better decisions to now associative technologies, where more and more of the intelligence is embedded in the machine, for example, like self-driving cars, where humans still need to have some associative